For those of you that are in the audience, my name is Jessica Taylor. I'm the Director of Operations for MSU. I just want to do a quick little recap on how your buttons at the bottom are going to work. If at any point in time during this presentation, you have any questions that you would like asked that you did not submit prior to today, you can go ahead and ask those in the Q&A at the bottom of your screen, side or top, depending upon what type of device you're joining us with. But that's where if you could put those questions, that would be great. Thank you guys so much, and thank you for being here today.
Thank you. I'm going to put up my slide pack. Again, welcome for a lazy Saturday afternoon conversation with Dr. Bhai. For those of you who are new to our sessions, they are very casual, and we want to make sure that everyone gets a chance to talk, so I won't talk too long. Again, my name is Lynn Wilson. I'm Vice President and Director of Patient-Centered Research. Jerry sends his regrets. He is not feeling well, and he has a lot of pain, and I think that's one of the things we're going to talk about today. You've met Jessica, and somewhere down here, Manuel is in a castle. Anyway, Manuel is our Chief Science Officer. Oh, there you are, Manuel. And for all of you who have not met Dr. Bhai is out of town. He's a world traveler, and he's in Detroit, did you say?
That's right.
Right. Okay, so I'm just going to go through a couple of slides here and let you know that for those of you who don't know, Dr. Bhai is our medical advisor. He's a neurologist at UT Southwestern up in Dallas. And he's also a faculty member. I believe you are a PI or a director at Institute of Exercise and Environmental Medicine at Texas. It's a mouthful.
Yeah, there's too much. Don't worry about it.
But he's our expert speaker today, and just a great joy to have him with us. What I'm going to do is come out of this and give Dr. Bhai a chance to talk to us a little bit about aches and pains, and then we'll take questions.
All right. Well, I don't have slides.
And, I know you don't.
I just want this to be a conversation. And, first I want to thank MSU for organizing this. I specialize in treating myositis, and it's you, people living with myositis, that inspire me. I know, and I hear you, and MSU hears you, that pain is a big component of this disease and an often overlooked component of this disease. So not only do you have to deal with delays in diagnosis and treatments that don't work well, and the side effects of those treatments that don't work well, you have to deal with pain. And I think that makes life very difficult. And so I'm inspired by people like you who work through the disease, who work to thrive and get past it. And my goal and my research is to help make that better, right? So thanks for being here, and thanks for taking a step to just hear out what we have to say about, at least my opinion, on how to treat pain in myositis. The short of it is there's no miracle treatment, but we'll go over some thinking around it. I'm just going to talk for another minute or so, and then we can just go into the questions, because I think it's what you ask that's the most important, and we'll have teaching points from there. The big picture about myositis and pain, it's tough to understand where it's coming from. We have pain from inflammation, and then we have pain not from inflammation. So pain from inflammation, right? Patients will often say, well, I'm in a flare, I have pain. And then from the doctor's perspective, we don't listen to you. And we say, well, your CK is better, your strength is better, your rash is better, you're not flaring anymore, let's go down on the medicine. But the pain stays. Now, pain is not a typical indicator of a flare. So sometimes patients will say, well, I'm hurting a lot, I need to go back up on the steroids. And steroids fix a lot of things, right? You may notice you feel better on steroids. The problem is it's wrecking your body in the long run, and that's not something that we want. And when we use medications that aren't steroids to treat myositis, it doesn't always impact the pain. So we're in a bit of a pickle, right? We can't fix it. We don't know where it's coming from, and we don't know what to do after that. I would say there's two main treatment modalities. So I'm assuming you are not in a flare, and then the pain is chronic, right? That seems to be the most common scenario where most people were able to get control of the myositis, and then there's remnants. There's either weakness, there's deconditioning, there's pain there may be joint pain. What do we do about that pain? I know I've gone over a minute today. Well, I want to get to the
That's all right.
questions, but I see it in two ways. One is non-pharmacologic and one is pharmacologic, non-drug and drug. I like the non-drug approach, but it's not easy. The non-drug approach is a lifestyle change. It is exercise. Exercise is your treatment. It's mindfulness. It's stress management. It's being social. It's working on your mental health and emotional health and spiritual health. Now, I don't want to sound too far out there because doctors typically don't talk this way, right? But I think it's very important that, especially the exercise part, we focus on that, right? All the other things are very important. And I'll go into some of the science of that as I answer questions. But I think exercise is key to helping your pain in the long run. Now, I know that's difficult because you're in pain, you may feel weak, your energy may feel low. I understand all that. What I'm saying, though, is that even a low level of exercise can be massively beneficial. And you know what? I will go past a minute because I think it's important to talk about this. So my research is based on this, essentially. What happens when you have myositis is your muscle gets damaged, right? We know it with the CK. What happens after that is that your mitochondria, which is more prominently damaged in IBM, but your mitochondria, the thing that produce energy in your body, they get damaged. And so, for example, with my research and clinically, when I exercise patients, I put them on a bike. It's like those Gatorade commercials. They got things hooked up to them and we measure what their fitness looks like. Their physiology looks like a mitochondrial disease. I repeat that because a mitochondrial disease is very different than myositis. But what's happening is when I exercise patients with myositis, if I didn't know anything else and I just looked at the numbers look like a mitochondrial disease. So what I think is happening is one, and the pain that you all describe also is what's described in other muscle diseases like mitochondrial diseases. Same kind of achiness that's so difficult to treat. So what happens with myositis is the muscle gets damaged, you get mitochondrial issues, and you're getting out of shape. You're gaining weight. Now, that's not a personal fault, right? When you feel sick, you don't exercise, and that's normal. But as you're not exercising, you're deconditioning. Okay? So now, it's so true in medicine, if you don't use it, you lose it. So even if you didn't have disease, your metabolism, your mitochondria, everything downregulates, meaning your body says, well, hell, I don't need this. I'm not using it to its maximum capacity. Let's not waste energy on this and start to get rid of some of these things. So your fitness level is now even lower. The disease has knocked it down. So you're out of shape. The disease has hurt you. You might have some weakness. Your lungs might be affected. So now you're starting at a really low baseline. What happens in mitochondrial patients, again, I'm so sorry I'm talking so much because I want to hear from you. What happens with mitochondrial disease and energy issues is your muscles don't produce enough energy. So what I hear from patients is it feels like I'm sprinting. It feels like I ran a marathon. I barely did anything, and wow, my muscles are achy for a week. That's what happens to people who don't have disease who exercise too hard. That's what happens to people who have mitochondrial disease without myositis. If they exercise some or too hard, they end up with similar symptoms. And I think that's what's also happening in myositis. So it's basically an issue of you are, unfortunately, because of your disease, out of shape. The disease has hurt your muscle. You're not using it, so you lose some of that exercise capacity. So now when you used to do something so simple like carrying groceries from your car to your home, that is really stressing your muscles. Now, you may not think that's a stress to your muscles because, hey, I just did that 5 years ago, or I'm 40, I should be able to do that. I don't feel that weak. But internally, your muscles are struggling to do that. Mentally, you might think you can do it. Your muscles are saying they cannot. So that is the equivalent of running a marathon for you now. And that explains a lot of the pain. So when you go day to day, just doing simple things, it's not so simple for your muscles. Okay? That day-to-day simple activity gets hard. And compound that over years of not exercising, well, it's only going to get harder. And I think that's a primary driver of the pain that's left over in myositis. Okay? The way to treat that is such an easy answer. It's exercise, but it's even easier than that. And I think there's hope with that. So if we were in our own room, I'd have you raise your hand and say, who thinks no pain, no gain? Who thinks that when you exercise, you really have to push yourself each and every time? So if you're good test takers, you would say no to those answers. But that's not true. So if we look at athletes, right, professional athletes, weekend warriors, just everybody, whether they have disease or not, the best way to improve your mitochondrial health, and there's research that shows this, the best way to improve your mitochondrial health and your metabolism is to do something called zone 2 exercise. Okay, that's the first learning point today, zone 2 exercise. So zone 2 exercise is simple. Don't Google it. You can look it up later. Just focus on me. Zone 2 exercise is easy exercise. You should be able to have a conversation like I am right now. It's a one-sided conversation, but you should be able to talk like this during exercise, okay? So if you're able to talk like this, all that means is that you're not working that hard, which is good. Zone 2 corresponds to a particular heart rate zone, meaning an easy zone. Zone 5 is sprinting. Zone 1 is just living, okay? We very easily, I love to exercise. I think I'm in shape. But even then, I very easily get into zone 3 and zone 4, and I have to hold back. And for you, zone 2 will be even lower. That heart rate zone is probably 110, 120, which is like nothing. So people who have heart rate monitors here, you may notice that you barely do anything and your heart rate starts to go up really fast. You are past zone 2. That's good news for you because that means your bar is so low for your fitness that if you do simple activities consistently at zone 2, I promise you over 6 to 12 months, you're going to notice huge benefits if you keep up with it. Okay? The reason zone 2 is beneficial is that it maximizes aerobic health, mitochondrial health, and minimizes the risk of injury and soreness. Okay? When you go into zone 3, you start increasing soreness. You're increasing metabolic load. Zone 4, you're in trouble. You're going to be sore for sure. And fitness is a brick by brick kind of thing. I need consistency. I don't need something that you do for 3 days and then you're sore for a month and then you can't do it. Or worse, you fall and hurt yourself. Okay, and that zone 2 exercise can be, I see a comment here, it could be walking, totally fine. It could be slow walking. You should just be able to talk. It could be cycling, it could be elliptical, it could be swimming, it could be rowing, it could be anything. It could be walking your dog. It could be walking in the mall. But you just need to get the heart rate up a little bit and still be able to talk. It's called the talk test. So if you Google zone 2 and talk test, that's what will come up. If you can only speak a phrase, a couple of sentences, you're going too fast. And your metabolism is not an on-off switch, just like your immune system is not an on-off switch, as you all know. The important part here is if you get out of zone 2, your metabolism starts to switch. So you start to lose the benefit. So even say you spike to zone 4 because you started to get excited and said, well, my song is on, I'm going to go fast and then slow down again. You went into zone 4 and then slowed down back to zone 2, but your metabolism doesn't just turn off like that, back to zone 2. So what you really need to do is stay in zone 2. And then at the end, if you want to pick it up, sure, do a little bit. Or you can have a day where you do something a little faster, a little slower, a little faster. But with athletes, with all the studies that are done on professional athletes, they spend 80 to 90% of their workouts in zone 2, meaning they run slow to eventually run fast. That makes sense? They run slow 80 to 90% of the time so that when they race, they can run fast. And what they're doing is increasing mitochondrial density. They're improving the efficiency. What's happening is your engine to produce energy is really tiny, is shrunk. So the more of this zone 2 business you do, the bigger your engine will get. Okay? And that's what you want. You don't want to ever rev your engine. What you're doing when you get out of shape, when you have muscle disease, when you're not exercising, your engine shrinks. When you rev that engine, that's what leads to a lot of soreness and pain. And that's not the only cause, right? Some of the other issues that happen are muscle imbalances. So I notice a lot of patients who their hips rock. You might notice too that you might see your pelvis rocking, or you feel like you're a little off balance. And that's because of that proximal leg weakness, right? So when you have proximal leg weakness, typically what happens is your pelvis muscles, your hip muscles get involved too. And when they get involved, they start messing with your biomechanics. So if you think back to pre-myositis, if you ever twisted your ankle or hurt yourself, you might walk funny for a little bit, right? So when you walk funny, what happens? Other muscles get activated in a funny way, and now joints hurt, muscles hurt, you feel sore, things just don't feel good. When I was 15, I could do that and wouldn't feel anything. Now I'm 35, and when I do that, I don't feel good for a little bit. So I'm not old. I feel old, you know? So even the simple things, a little tweak here or there can cause pain. So the other thing to do is to strengthen your muscles, not just aerobic. And that's where physical therapists are really, really good. Because I bet if I tested your hip strength, if I had you lay down on your side, if you think back to those spandex era times where, you know, you're laying on your side and you raise your leg up, that's for the gluteus medius muscle. And that's what keeps your hip stable. Most people do not work that muscle out. But that's an important muscle that gets weak and makes your hips rock and can cause low back pain and joint pain. That can trickle down to your knee and make your knee hurt, right? So some of those simple things of, well, if we strengthen that, that will help prevent some of the pain that you have. But it all takes work. Okay, it all takes work. And I wish there was a simpler solution. I really hate giving drugs for pain in myositis, but it's sometimes necessary. And the way I think about those drugs are that they're a crutch when you break your leg, right? If you break your leg, it's not like I would say, walk it off. I would say, use a crutch. Let's get you back to normal. And during that time, that's when you should be exercising to get back to normal. And then over time, you take away the crutch, right? You take away that pill. So there's lots of different meds you can use. And, you know, that's something important to talk to your doctor about. Unfortunately, they're non-specific. They're the ones typically used for nerve pain or fibromyalgia type pain. There's a big list of those meds. What I really never use are opiates. Okay, I know some people do use them and their doctors prescribe them, but boy, not good meds. All right. I'm going to stop yapping. I think there's a bunch of questions.
Okay. Thank you. All right. I'm going to share the questions. Now, these questions are questions that were that you asked to be answered when you registered. So those are where we're going to start. And why is it there?
I would give a plug here, not just for my research, but for other people's research too. We don't learn these things without your involvement and your guidance, right? It's what you tell me in the clinic. It's what you participate in to help us figure out this stuff, right? With this exercise studies and other people's studies, because unfortunately, we just suck at treating myositis, right? We need better treatment. We need better understanding. And that starts with you. I'll stop there.
Can
Let's
you
answer
see
some
that?
questions. Yeah.
Okay. These are the first set of questions, um, medication related. If you see that and you want me
Yeah.
to read it out, I don't
No, I
need to do it.
can
Go
take a look.
for it.
A massive disclaimer, people. I don't know your history. So whatever I say is extremely general and something that you have to talk to your doctor about, because treatment with medications are very specific, not just to your condition, but also to your labs and other medical history. So whatever I say, other than exercise, don't go implement. Okay. Take notes, talk to your doctor about it, and go from there. So generally here, so over-the-counter pain relief with azathioprine and how that can be difficult on the liver. So, everything is a risk benefit, right? So just because you're taking Tylenol and azathioprine does not mean that they will synergistically combine and cause liver issues, but that's something that we monitor, right? So if you're not overdoing it on the Tylenol, your azathioprine has a good level, you've never had liver abnormalities, right? That's something that's okay. But there's several different kinds of medications. I think creams are good, right? There's a lot of those menthol kind of creams or those rubs. I think those are great if they make you feel better. I think Advil is okay too. But of course they have limitations, right? If you have kidney issues, then we don't like Advil, or if you have gastrointestinal issues like an ulcer or heartburn, we don't like Advil. Advil, I don't know if I should get too much into preclinical work here, but sometimes medicines like Advil perhaps do not help with muscle recovery after exercise. So when I exercise, muscle tears normally with exercise. That's just a part of it, and it recovers. But that is a medication that I try to avoid post-exercise because I potentially can harm recovery. How true that is, I don't know. We see it in preclinical studies. The next question here is with marijuana. So marijuana, I don't know what the true answer is with this. What I tell patients is if it makes you feel better, fine by me. I'm not going to stop you. There is harm from it too, where some patients get very nauseous or have issues in the GI realm, but if it's helping you, I think that's fine. Ultimately, any medicine that I talk to patients about is about making sure that it's safe for their personal medical history, right? So as we get older, I have to be more careful. So I'm not going to say 65 is old, right? It really depends on what your condition is like. I feel a little old at 35, but there's 75-year-olds who feel great. What we want to avoid is someone falling. So if a medication is calling you to making you feel sedated, that's not something that we want you to take, right? Again, I would much rather, I know you wouldn't agree with me perhaps, I would much rather muscle pain than you fall and break your hip, because that has a high mortality, and then you'll lay in bed, get clots or get further deconditioned or get weaker, right? So we just have to balance the risks and benefits of this. What do you recommend for body aches besides showering? It's a lot of that non-pharmacologic treatment that I was talking about. So I'll go through the list again. And I know it sounds funny, but pain is exquisitely linked with your mental health and central processing, right? Your brain. And let me give an example of how powerful the brain is, right? So we know about the placebo effect. There's some patients who have a condition called functional neurologic disorder. Has anybody heard of that? Functional neurologic disorder is something that messes with doctors. It's a difference between the mind and the brain. So if you look at a computer, there's hardware and software. If there's a hardware issue, I can point towards it and say, hey, look, the mouse is broken, or hey, the keyboard's not working. Easy, right? That's like when I do an MRI and say, hey, look, you have something in your brain. There's a stroke, or your spinal cord looks off, or you have arthritis. The software issue is harder to pick up in a computer, right? If you have Windows, you're familiar with the blue screen of death, right? I don't know what happened. Something in the software happened, and then it kind of fixed itself. That's kind of like the mind, right? If you're thinking something or feeling something, right? If I think of your favorite color right now, I can't point to where in your brain that just came from. But if you move your left hand, I could very precisely point on your brain where that's coming from. So patients with functional neurologic disorder have very real symptoms. Sometimes they can't walk. Sometimes they can't see. Sometimes something really hurts, or sometimes they can't feel. Those symptoms are real. But when we do every single test possible known in medicine, we can't find the cause of that. Okay? Just to highlight how strong the mind is in all this. And so when you ask, what else can we do outside of showering, I would say all that floofy stuff I talked about that I think is extremely important. So one is exercise, having good sleep hygiene, meditating, doing what you do for stress relief, right? Focusing on you. It's really easy to get caught up in this where, there's appointments and life is stressful and work and finances and the world is going crazy. There's shootings all the time. I mean, it's a stressful time. But, if you're going through this, it's important that you focus on you and figure out what do you need to do to take care of yourself. I think part of that is going to a mental health counselor. Part of that might be treating your mental health with a psychiatrist and medications. All right. So I think, and having a good social support network, right? MSU, we all did a study about caregiver burnout, right? So it's hard to always get the support you need when your caregiver might be burned out. So that's an important part of your care, but that's also where you can divvy up the support, right? It's not just your spouse, it's friends, it's family, right? It's a network of people that support you, and MSU is one of those. So all of those things I think are crucially important, even more than medications in treating the body aches. So if you're not doing those things, I really want you to do them. Vitamin D3, maybe it reduces inflammation and flares, maybe not, we don't know. What's the current understanding of statins in myositis? Also unclear. As you know, it's associated with necrotizing myopathy. Sometimes it makes genetic muscle diseases pop out without myositis. Sometimes it causes myalgias, muscle pain. Why it does that in some people and not others is unclear. I think this is also a risk-benefit conversation. So if your cholesterol is 300, you have a strong family history of heart attacks and strokes, well, boy, I don't want you to have a stroke, right? And if you need the statin, perhaps there's a smaller dose, perhaps it's a different statin. So there's different classes of statins, ones that are more lipophilic, like they like lipid and get stuck in the body, and other ones that are less. And you can cycle through different ones. I think there's also a lot of placebo around statins, right? So we know statins cause muscle pain. And I think people complain about it more or feel it more than it actually is there. So I think we have to be very careful about the actual issue with the statins versus the benefit of them. Again, because we want to prevent strokes. So it's all a risk-benefit conversation. LDN. I don't know what LDN is. I'm not familiar with that. But maybe someone can type it in the chat. So we talked about this with the prednisone tapering. Prednisone does several different things. Excellent. I'll come back to the LDN. I'll come up to it now. I don't know about naltrexone and myositis, unfortunately. I'll read up on that later, though. Thank you for bringing that up. Prednisone, I mentioned that it treats a lot of things, but it can also make your muscles feel better, but it's not necessarily treating a flare. So I'd be careful of conflating flare and pain together. It should be something you think about, but not a direct link always. You can go on to the next page. Exercise. All right. I didn't fully look at these questions, so it seems like this was planted here now.
There might be some
Thank you for
repetitive. Yeah. So.
We'll cycle through them. Thanks, Lori, for sending that study on self-compassion. Again, I think it's really important. One thing I can't stress enough is think about if If my body was hurting, how would you counsel me? You wouldn't say, come on, idiot, get over it and keep moving, right? I hope you wouldn't tell me that. So don't talk to yourself like that either, right? It's really important that you're kind and forgiving to yourself. And that's the basis of starting an exercise program, right? So I'd like, it's not that, hey, stupid, why are you so out of shape? Or why are you not where you should be? It's okay. I got to work at it. So I'd like to hear what the best practices are for exercise. So we talked about the zone 2 exercise. I think strengthening is really important to do with a physical therapist because there's different kinds of exercise. I don't want to get into the heavy weeds about weightlifting and resistance. The quick of it is there are exercises that tear your muscles more. And that's called eccentric exercise. And those are things we don't want to do. You're not trying to get big and swole. You're trying to keep your muscles strong. An eccentric load is basically, think of a normal movement that you do, like standing up from a chair. I know that can be hard for some of you. The eccentric part of that is when you slowly sit down. What happens is the normal movement of your muscle is to put force in and contract, get smaller. All right, I know this is going to go on YouTube, so this is a little embarrassing. I'm going to show you my guns here. Okay, you ready? I work out. All right, there you see it. Probably not enough. So when I'm pulling my arm in like this and strengthening the muscle, you see how it shrinks? That's called a concentric load. Your muscle wants to do that. So when you stand up, lots of muscles act together in a concentric way to stand up. Eccentric is if you're pulling the arm, you're adding force, but you're stretching the muscle. So the muscle's fighting that, but lengthening. That tears muscle. We don't like that. That's going to make your CK go up. Now, you don't need to make it so complicated. I think a physical therapist can help you with that. And what you do there is the motion that you're doing, you should do it. And then in the relaxation phase, you relax. You don't fight it. And that's where a physical therapist would help you with. So that second question is very important. How do you exercise when you're in pain? Because I just told you, you need to exercise. It's tough. I don't have a good answer for you. And this is where we struggle because I know it hurts. And I think what some of it can be addressed with is that really low intensity exercise and trusting the process. Okay. I like to ice my joints after exercise. That could be something else. Sometimes people like warm or cold showers. That can be helpful too. This is where also sometimes the medications can be useful. Right. So things like duloxetine or nortriptyline or amitriptyline or cyclobenzaprine. Those kinds of medicines I would say are like crutches. Right. I don't want you taking those without exercising. If I could force all of you to exercise, I would do it because I think that's the treatment, but doing it at a light level. I think that's what makes the difference. If it's causing pain, obviously don't do it. But there's a difference between injury and soreness, right? An injury is something that can be really sharp. It hurts, right? It came on rather suddenly. It's not getting better. Soreness is that achiness, right? I think soreness is okay. But the way to avoid some soreness is to exercise at a lower intensity. Take it easy, warm up, cool down, stretch, right? You have to do all those things. IBM, best practices, same thing, right? You want to strengthen muscles that are not super weak, right? So if they've become too weak, then it's hard to exercise them. But if you exercise supportive muscles, right, then those can help you compensate. It's like when you twist your ankle, right? You start using other funny muscles to walk around. Same thing. If your muscles are weak, there's other muscles being stressed. So those muscles should be strengthened. The back pain is happening probably because of poor biomechanics. That is difficult to treat, but there's massage, there's stretching, and then strengthening the supportive muscles. Unfortunately, I have to admit that we have to come to terms sometimes about what a new normal is, right? And I think a new normal, unfortunately, and I hate saying this, is that pain is a part of this. but we can do things for the pain. So I don't want you to feel hopeless. I think it's important to come to terms with pain is a part of this, and it may not fully go away. Right? As we get weaker, I can't fix those biomechanics. Right? As you get older, that arthritis is also going to compound on top of that. So do I want to put you through surgery? I'm not sure it would be that helpful if you can't recover from it, to fix your low back if there's arthritis. So I think it's a little easier to cope once we've realized, okay, this is a new normal, and I'm going to work with it and work towards a solution. Right? Just because there's not a cure doesn't mean we can't heal. Right? We can work towards pain relief. Someone put a link in there for PT. It is unfortunate. Physical therapy can be quite expensive. So take a look at the links on there. When is exercise too much? When you feel like it's too much, right? It's a lot about how you feel, and that's what's going to judge it. Go to the next slide. Symptoms. Why do I become so tired? Oh, and so we talked about that, right? I think it's because you have a smaller engine. I think that's the issue. When I overdo anything, I vomit. I think it's the small engine. So if something like a simple activity of daily living, right, something that's just part of life, I think it's important to listen to your body, rest, recover, and that's what's going to help you, right? If carrying the grocery from the car to the house is difficult, take less groceries, put it down, rest, have help, right? Those are ways to help with that. Can you still have aches and pains from myositis if your EMG and MRI are normal? Yeah. Also, is it possible for your CK to fluctuate largely? So the first part of that question is, if you're yes, so this speaks to how you get residual pain even when you're not in a flare. Okay, so your muscle metabolism is not recorded by any of those things. Is it possible for your CK to fluctuate largely if only on Plaquenil? I'm not quite sure. It depends on several different factors. So I don't know how to answer that question. Is pain typically nerve or muscle? It can be both. In myositis, it's typically muscular, but nerve pain can follow too. For example, if you have poor biomechanics, you get arthritis. So your bones degenerate if you don't like pound them. So like when you walk and run, your bones get stronger because they feel tension and force. So if you're not walking, okay, your bones are becoming weaker. If you're taking steroids, your bones are getting weaker. If your vitamin D is low, your bones are getting thinner. So imagine all of that's happening. Well, now you get arthritis in your back, and now you have a radiculopathy, right? Sciatica, a pinched nerve. Now you have bad nerve pain. You're taking steroids, you get prediabetes. That's a risk factor for neuropathy. You don't have to have diabetes to get diabetic neuropathy. Prediabetes will do it. Or if you get diabetes, you get bad neuropathy. So all of those things can lead to nerve pain. Can myositis affect different parts of the body other than the shoulders, hips, diaphragm, lungs? Yeah, if it gets very severe, it can affect even more muscles down the arm and down the leg. I've seen patients who are bedbound, unfortunately. It can affect your swallowing muscles. So you have to be really careful to make sure if any of those changes happen, you tell your doctor so that they can treat you more aggressively or figure out what else might be causing it. If it's affecting your lungs, right, I think if you have any shortness of breath, it's important to talk to your doctor about it. There's tests that we can do to quantify that, to look at that more carefully, and that's an important thing. And then how common is it for people with IBM to have tendon pain? It goes to the same thing with biomechanics. Your tendons too, if you're not using them, they become less stretchy. And as we age, they become less stretchy. So you can imagine if you had inflammation, and it's like an old rubber band you find in the drawer. Those don't like to stretch much and they snap. So you have to be careful and slowly warm up before you exercise and slowly cool down. How should we talk to our physicians when they insist that there's no pain with myositis? Good luck. Doctors can be a little hard-headed sometimes. I know I am sometimes. I don't know what that answer is. Some doctors get very defensive if you try to educate them, which is unfortunate. And, I I think one approach could simply be, well, whether my pain is myositis or not, my muscles hurt. What can we do about that? Well, I've already told you a solution, and that's all the non-pharmacologic things that you should be doing. The pharmacologic things could come from your doctor, and those are treatments that are typically used for muscle pain. Okay, but I wouldn't be discouraged if your doctor doesn't listen. You know, they're human too. They're busy. They're seeing a ton of patients, and you know, I understand that side too. But I think it's important for you to advocate for yourselves, right? To say that, okay, it doesn't matter if you believe myositis has pain or not, right? I have muscle pain. Can you help me treat that? Doctors like treating things, right? I tell people you should have less doctors in your lives because we break things sometimes. But you need, they like treating things. So if you give them a symptom, they can potentially try and treat it. And we have treatment for that. So it's like when you go to a surgeon and you say you have an issue, well, they're the hammer and you're the nail, and it makes for an easy thing. So I would talk about it perhaps in that way. What do you say to a doctor when they tell you pain is, oh, okay, well, I wasn't reading that question. One of the best doctors, I shouldn't be in pain yet. I cried you to pain. You know, best is a very subjective and subjective term. But you know, just because they're very knowledgeable in the area, or they don't believe in pain and myositis, doesn't mean that they're not the best. Right. And I would perhaps even focus it away from that and say, unfortunately, I am in pain. I don't know from what, my muscles hurt, whether it's myositis or not. Who cares? Do all the non-pharmacological stuff I told you to do. But also, there's other treatment, right? So those are depression and anxiety treatment medications. And those are something that you could talk to your PCP about. You could talk to your neurologist, rheumatologist. We're all familiar with those medications. But I'm sorry that you're going through that. I know it's difficult when you go to someone who should be in your corner, who you trust, and hopefully they trust you, and that relationship isn't what it should be. So I apologize. I know that's not a fun thing to deal with. We can go to the next one. Yep. I've been struggling for some time with this now. The effect on us after we exercise. Yep. It's like twisted muscles when you're getting. Okay. You know, that speaks to all of this too. And I think, remember, I think your engine is much smaller. And that's what my research studies are showing, that not only are patients or people with myositis out of shape when we look at the numbers, but the physiology looks like a mitochondrial disease. It looks like there's a problem producing energy in the muscle. And so the way to combat that is to exercise now, right? With what you are now, not what you were, not what you want to become, but what you are now. And that's completely okay. So that should be really simple, easy exercise that puts you in zone 2. Okay, that you should be able to talk. Any harder is going to lead to soreness. Female 59, I have IBM and mitochondria. I attend an exercise program. We are working to strengthen the muscles. Am I doing all I can? I think doing aerobic activity is also important to do. And so not just strength training, but aerobic. Are you doing all that you can do? I think stretching is important too.
Oops,
Sorry. And then I'm in a flare right now. CK's down. Should I start walking on a treadmill? I think it's okay to slowly walk. And someone mentioned aquatic therapy. I think that was Jason. I think that's a great idea. We exercise patients almost no matter what. Don't fully quote me. There's probably an exception somewhere. I tell all my patients to exercise. I don't care. You must exercise. I don't care what muscle disease this is. You need to exercise. Unless there's heart involvement, then I get the cardiologist involved. That muscle, I don't mess with. But skeletal muscle, any kind of muscle disease, even if your CK is coming down slowly, I think it's okay to slowly walk and start moving. The longer you sit, the more out of shape you're getting. Okay. But what's usually limiting people when they're in a flare is that they feel terrible. Right? That's what usually stops people. So if you feel okay enough to start moving around, I think that's a good thing. IBM diagnosed 2018, 24/7, legs, muscle pain. Doctor lowered pain med to 15 morphine. Yeah, this is a tough one. I don't know, you know, I really try to avoid opiates, so I don't have much experience increasing to opiates. I don't and again, I don't mean to downplay any pain. I know the pain is very significant. Sometimes opiates may be the only solution. I wish and hope, and maybe it's wishful thinking, that we're able to treat this without opiates. And so then I would pull out other meds that I mentioned earlier and try them in combination, as well as the non-pharmacologic therapies. I don't know how to fix your pain, and I apologize about that. I think those are all the slides.
Yes, those are all the slides, and now we can move. We still have some time left. We can move to the Q&A box, Dr. Bhai.
Sure.
And
Sure.
just, we'll give you round 1, 30 seconds each per question. No.
Yeah.
You
So I
can
see
just
a
start at the top and go down. If you feel
Okay.
like you've answered them, go to the next.
Okay, so we'll do that. And okay. So I have abnormalities in MTHFR and folate in myositis patients, particularly those with pain. I haven't been looking for vitamin deficiencies in those with pain, so I'm not sure what the correlation is. I cannot think of a pathophysiologic link between the two, other than perhaps certain medications, for example, like methotrexate, but nothing particular. What do you mean by mitochondrial deterioration? So your mitochondria are little bacteria that went into your cells a long time ago, and they formed a lovely symbiotic relationship. They need us to survive, and we need them to survive. The mitochondria produce energy for us, ATP. Now, what happens with deterioration is the whole metabolic system becomes less efficient. You get decreased number of mitochondria, okay? So if you look at somebody who exercises a lot, you'll see more mitochondria. And you'll look at how metabolism from oxygen coming into your mouth, into your lungs, or nose, into your lungs, through your blood, into your muscle, to the mitochondria, that whole processing system gets more efficient. So the more you exercise, the better all that gets. If you don't, and you have disease, your mitochondria do deteriorate. Can you explain about how metabolism and exercise are related? So we just talked about that. The more you exercise, the better your metabolism gets. There's no drug for this, unfortunately. If there was, oh boy, that would be fantastic. Although it'd be terrible, right? We wouldn't get outside as much. I'm currently trying to taper prednisone. I'm at 6. Lowest I've been, my doctor wants me. This is a long question. I'm just reading through to paraphrase it for you. I don't know how, I'm not quite sure how to answer this question, so we're going to skip it for now. It's a specific question about how to taper steroids with potentially IVIG, but I don't see a clear question. So we'll skip that for now. I have a conundrum of no treatment seemed to work. Anytime we try to increase the pain, stretching thoughts. This question goes along of, well, I exercise and I do everything that I can, but I still have pain. I would try to really focus on the zone 2 business. I sound like a broken record, but I can almost guarantee you that your heart rate is probably going much higher than it should. And I think that may be contributing to some. There's also this part of the coming to terms, and we don't have a good reason for why some people are in more pain than others. Pain is really multifactorial. So I would really try to make sure your biomechanics are okay, that we're addressing if there's stretching that needs to be done, massage, and then that slow exercise. There's a question about dead muscle in necrotizing myopathy, and it happens in myositis as well. This is a massive problem in myositis and muscle disease in general. When muscle dies, it's not coming back. So when it gets replaced by scar or fat, it's not coming back. Okay, this is why it is insanely important to catch this disease early and treat it aggressively. So if you are not getting better on your treatment, you need to go to your doctor and say, this needs to be more aggressive treatment. Right? You cannot sit there in a flare for 3 months. Right? We need to knock that out and knock it out fast. My baseline heart rate is low. Is my goal still zone 2? Yes, everybody's, no matter where your heart rate is, the way to actually calculate it is it's a quick and dirty way is 220 minus your age. And then there's percentages. So it's around like 70% or so. But if you just Google zone 2 calculator, you'll find a bunch of calculators online where you can find your heart rate zone. I would say ignore that. Go by your talking ability, because your heart rate will fluctuate if you haven't slept, if you're feeling sick, if you're dehydrated, right? But if your talking will reflect all that. So you don't need to calculate zones for each of those things. Just if you're able to talk and go slow, that's a good thing. How long should you exercise each day? I wish all day and all night. That would be fun. But, about just the typical guidelines, 30 minutes, 5 days a week, something like that. If you can do longer, that's even better. Do an hour a day, 7 days a week. This doesn't have to happen all at once, right? You can do it in little chunks, right? If you can only do 10 minutes, that's fine. Do 10 minutes sometime later. We've sat for an hour. That's a long time. So after this, you should go walk around. But this could be your 10-minute walk, right? I used to run marathons and can now run for only 1:30 at a time. Do you think it's possible to get back to running? I think so. I think it's about where you are now, not where you used to be. So it's important to have realistic goals, but have goals. And over time, things will get better. It's just a slow progression. So you have to stick with it for months and months and years. Okay. So this is not a quick fix. If post-exertional soreness resolves within an hour or two, totally fine. That's great. Is that okay? There are studies that show practices such as self-compassion can help. Yes, I agree. Any comments on developing these practices? A social worker is a great place to start. I love a website called psychologytoday.com where you can look up if your insurance is taken by counselors, what the counselor's bio is. It's kind of like speed dating where you open up to somebody and you realize, hey, it doesn't work. And then you got to go to somebody else and open up again. Whereas this might be a little more targeted. So I think that's a good thing. And there's several tips online too. If you just Google self-compassion tools or methods like a gratitude journal or, that's something that can be quite useful. And journaling is really good.
This is where I'm going to put in a shameless plug that MSU does have a monthly mindfulness group where
Excellent.
we talk about a lot of these practices. Like he's talking about the gratitude journal and mindfulness and compassionate. So I just wanted to say that real quick. Sorry.
Yeah. Oh, no, that's perfect. I know I'm being mindful of our time. We have a minute left, I think, or something like that. So, one of the questions, the themes that seems to be here is that, my day-to-day activities make me exhausted. I would say that it's important, and does that count as exercise? Again, I know you've probably heard, so some doctors don't think exercise is important for myositis. I think they're wrong. And then others will have already told you to exercise. So I don't know if you came here looking for a different thing or a miracle, but I say exercise because it has a stress relief too. So even if you're working or you're chasing kids or doing whatever, I want you to have that time to yourself, right? So if you're walking around and if you're working and you're walking around all day, I would say don't let that be your exercise. I want you to get outside. I want you to have time to yourself to reflect. That's part of the benefit of exercise, right? Where you don't have to focus on anything else other than you. Now, I know the pain, the treatment, work, life, family, all of that can make you exhausted. But this is where I say this is where you need to make you the priority, right? And first thing in the morning, maybe you go for a walk and get your exercise done. There's a question about mitochondrial supplements. Those are not shown to be helpful, unfortunately. There's a question about acupuncture. I think that's totally fine. If you find that to be helpful, go for it. All right. I think that's it.
Thank you, Dr. Bhai.
No.
Let's see, we're at 4:50, 58. Is there anything else that you want to relate to us? I've just got a couple of slides to finish up. And
Sure, you can go ahead and finish those up.
okay. Well, then.
Oh, okay. Can I just say thank you? Thanks everybody for being
well,
here.
don't leave yet. If you can hang on for just a couple of minutes.
Sure.
This is my personal statement here, but and I have to say that Dr. Bhai was a significant part of our ability to get this work done, but I just want to let everyone know here that your pain is real, and don't let anyone tell you differently. You're hearing it from Dr. Bhai too. But one of the first conclusions on our paper on pain profile and opioid medication use in myositis patients was, it's a fact that pain is common in myositis. And that for every one of you who has had a problem with talking with a doctor about pain, don't ever let anyone diminish how you feel. And the best thing that we can say, and Dr. Bhai, there's a strategy about how you talk to your doctor, which I'm going to give a plug to your speech that you're speaking at the IGNS conference. But download, there's a link here, download our paper that was published in Rheumatology last year. Take it to your doctor and have a conversation, push it across the table, and say, let's talk. And use that as a launching point for having some open, honest discussion about pain and how it's making you feel and how it's impacting your life. So that's it. I would say something a little bit more radical about people who are best, specialists in the field and reject the notion that people have pain, but I'm going to keep my mouth shut on that. So we've got those links in the chat box too. The last thing that I wanted to do is turn it over to Jessica, who's going to talk about the rest of the things that we're doing, but don't leave yet, because we're going to tell you a little bit more about Dr. Bhai is going to be around later in the month, not with us, but with IGNS, and he's going to do some more talks. So
Yes. So we're gonna go through these quickly, guys, because these are all gonna be posted into our social media platforms. But this is just a kind of a quick look at what's happening this coming week, starting with Sunday, May 7th. The biggest thing that our new event that we're going to have that week outside of our normal support sessions is going to be a special event about what brings you joy. We want to talk about and have discussions on the different things that make you joyful. We'd love to see pictures, whether that's your garden, cooking, talking, we want to focus on things that bring us happiness outside of myositis, because I think that kind of ties right into what we're talking about is what do we do for ourselves that give us happiness and joy. So next one. Next slide, please. And then this is the week that we wanted to talk about. Dr. Bhai is going to be doing not one, but two different talks at the IGNS conference, which is May 20th and 21st. Registration is free. It's an online virtual. If you have never attended one of these, I highly, highly recommend. I learned so much information every single year. Dr. Bhai is specifically going to be talking on Saturday, May 20th. His first session is at 8:30 Pacific, 11:30 Eastern. And that one's going to be on, correct me if I'm wrong, how to talk to your doctor, like how to prepare for your appointment. So that was kind of interesting that we had some of those kind of questions ahead of time today. And then you're doing a second session also on that Saturday in the afternoon at 1 p.m. 1 p.m. Pacific, 4 p.m. Eastern, and that's going to be on the complications of neuromuscular disease. So that is a don't miss. If you loved hearing from Dr. Bhai today, you must attend.
That's too much talking on my end. I'd rather hear from you all.
All right, and then we are going to be doing a special event as well on May 23rd called the Disability Room. And really what that's behind is we want to talk about that a lot of people have a lot of issues calling themselves disabled? What does it really mean? How do you feel about that word? And more importantly, what's the history of the Disability Act? Like, how did this all get started? So that's going to be a really new and interesting Zoom group that I hope you will join us. And then if you can go one more. And then this last one, I definitely want to highlight the mindfulness discussions that we'll be having on May 31st. We are going to be doing vision boards. So that's going to be our creative project, is kind of like, what's our vision for the rest of this year? What do we see ourselves happening? Great time to goal set, maybe our exercise plans. I can see a lot of zone 2s going to be on those vision boards. So I hope you guys will join us for that. And I think there's one more. Yep. And then I just want to remind everybody, since it is May Awareness, that MSU is not here without all of you, and that we want to remind you to please spread awareness, but also if you find it in your hearts to give, so that we as an organization can keep on giving. We are an all volunteer-led organization, but as you all know, that does not mean that everything that we have and offer and do does not cost. Plus, we have our wonderful financial assistance program. So I think that was it. That's it for me, and I'm so thankful for today's session.
One quick thing, Jess.
Yeah.
For those who actually attend our normal third Saturday Zoom support group, that's actually going to be on the 13th. That's going to be on the 13th instead of the weekend of the 21st because of the IGNS.
Because we want to be at Dr. Bhai's talk. That's really what it is, guys. We want to hear Dr. Bhai, so we had to move it. And Angie, for the vision board, it's the 31st of May.
So I want to thank everybody. If there's no other comments from our panel, I just like to thank everybody for coming. We will be recording this, so you will be able to visit it again. I know was a lot of information, and I would like to get Dr. Bhai back. I think we're going to have to chain him down because he travels so much. But I know you enjoyed this, and if you have some ideas of what you would like for him to talk about in conversation number 2, when we can get him back, put it in the chat or send us a note, either Jessica or Jason or Manuel or I, a note about an idea for another get together with Dr. Bhai. So thank you.
Thanks for having me. Thank you everybody for joining. I really appreciate it. And you can do it.
Yeah. Well, together we can do it.
Yep.
It was wonderful. Thanks, everyone.
Thank you.